Bismillah ar-Rahman ar-Rahim. We had a discussion on the 9th of November 2024, and the title of the discussion was dexmedetomidine versus ketamine midazolam sedation in awake fibro-optic intubation with topical anesthesia in suspected difficult airways. And as you can see from the title, the supervisors in whom Osama NOFAL was the chief of them. And the picture shows the discussion board where I was present with Dr. MOHAMED ABDEL, which is a professor in Asr Al-Aini. And you can see from the lower part, the new drug that he announced, which is called Rifky, which is a novel short-acting benzodiazepine, which can, with a short duration, which can help in the process of sedation during awake fiber-optic intubation. And this is the conclusion of his thesis, where he proved that dexmedetomidine is much better as a guide for tolerance of the patient, but definitely the memory recall was much better with the midazolam ketamine group. This is the beginning of the thesis, where I can see the three points whenever you are you want to anticipate in a speedy way the anticipated difficult airway using finger by knowing the temporomandibular joint and mouth opening and the mandibular space by the measuring by your fingers. These are some of the mistakes that I discovered during the thesis. He had a very long paragraph, and of course he used he used a very long paragraph falling all over the page, and these are some mistakes in his reference where I couldn't find it, and at the same time one of them was in a different language, so I told him he ought to translate it. At the beginning of the discussion, he kept talking about the including and excluding criteria again, so no need of all this talking. And during the discussion, he was biased to the tool which was constructed by Dr. Osama NOFAL, where he created a tube from the Nelaton tube, where he made distal fenestrations and covered these fenestrations with a gauze, so that whenever he injects from the opening of the tube, this local anesthetic will be spread all over the cotton. This cotton will assure that the local anesthetic will be in complete contact with the mucous membrane, giving a much better long effect of the local anesthetic. So I had a conflict with him regarding this point, because he began to be biased all over the discussion sector, where he began to show that most of the difference between his work and other was correlated to his topicalization by using this tool. And these are some added information that I got from the internet. As you can see, that the fiber-optical intubation can be aided by the iGel and ambu aura gain laryngeal mask. As we can see here, a patient I find difficult intubation. I use this aura laryngeal mask to intubate, as you can see. And we, of course, whenever we want to begin to anesthetize the nose for the fiber optic, we use xylometazoline drops, and then we followed by 4% lignocaine, and then 2 puffs of 15% lignocaine. This is capable to give anesthesia to the nose before intubation. Of course, we never remove an endotracheal tube to minimize the trauma to the airway. I ought to soften it in warm water at temperature of around 40. And he didn't mention the type of scope he used. So this is a scope where he, which was used in 0.3, which is Carl Stoll working length, is around, as you can see, 65 centimeters with distal tip diameter of 3.7 millimeter. Of course, this is the tolerance of any patient, the grade according to facial Gramma's score. Of course, whenever I reach nearby by the fiberoptic bronchoscope near the course, I inject the local as I go forward. So sometimes we use a epidural catheter instead, so in the working element, so that we can properly spread the local anesthetic. From the good thing to assure that you are in a proper state by the endotracheal tube is using the ultrasonography. It was found that the combination of sufentanil and tetracaine can increase the duration of effect of local anesthetic. And then compare different types of local block of the upper airway during awake fiberoptic intubation. Of course, we know that they are a nebulization method, original nerve block, or spray as you go, the three methods. It was found that there is no much difference between them, apart from that the regional nerve block to block the branches of the vagus and the glossopharyngeal nerve is much invasive, and it could cause a complication. And whenever I nebulize around 2 millimeter of 4% lignocaine, of course, we can calculate that's about 80 milligram. You see, only 25 is typically absorbed from the mucous membrane. So around 20, only 20 milligram is absorbed. This is how can you calculate or estimate how much will be absorbed. Of course, Matowick says that there is nothing 100% success regarding the fiber optic bronchoscope. As we can see, none of the new tools are 100% success, but we can use both of them in the same time. As you can see, the patient, the anesthetist is using the fiber optic aided by the video laryngoscopy, as you can see, and this is another way, of course, using the Mac-Cross video laryngoscope to aid the intubation by the fiber optic. And these are the some of the flexible fiber optic bronchoscope stylet. We have the what we call the Shakine, as you can see, and the other one is the bone flesh intubation stylet. Sorry. Of course, the hemodynamic changes during the fiber optic bronchoscopy, it's affected by these factors. As you can see, you can follow these factors, and these are some of the video laryngoscopy and other laryngoscopes. And these are two cases where there was a difficult intubation in it. Of course, there was a tube in the floor of the mouth, and this is a retropharyngeal spread of a thyroid. So these are two patients where if there is an anticipated difficult intubation. So this is the figure after removing of the tumor. The patient had amyloblastoma. You see. And this, I'm sorry, these are the different types of the laryngeal masks. Of course, we have the first and the second and third generation. The second generation is the the one where we can introduce through it the endotracheal tube. And this is an additional information about what we call the WHY use in electromyography. This is a tube where we attach an electrode kit at the point where it touches the vocal cords, and we can stimulate this heat by electricity and elicit the contraction of vocal cords. So it is a method to predict that the recurrent laryngeal nerve or the vagus are being affected. Of course, it was not found that it was found that it's not that useful. And this is the picture to give you a hint about the supply of the face sensory. Of course, we have the trigeminal and the glossopharyngeal and the vagus, the three nerves which supply most of the face. And this is how we go through the nose, and we can see the inferior turbinate where we ought to bypass, go through the floor of the mouth to avoid bleeding. And this is the anatomy of the larynx, showing the recurrent and the superior laryngeal nerve. And this is the landmarks of the local block of anesthesia for the awake intubation. We can see the hyoid bone in the upper part. Of course, we have the cornu of the hyoid bone where we inject the local anesthetic, and this is the thyroid, and this is the cricoid. This thyrocricoid membrane we inject to block the superior laryngeal nerve. So this is the anatomical picture I got from Mysore. These are the way to installate the local anesthetic spray, either by injection, Mackenzie technique. This is the way we use a special cannula and injection to make spreading. And this is the way where we put 5 millimeter or 5% lubricate to a nebulizer, and the patient keeps on inhaling for amount of time to assure that the upper airways are size. As this is the sonography of the main cartridge of the hyoid and the thyroid and the cricoid cartridge by sonography. And these are, of course, picture showing the patient with anticipated difficult intubation. And this is the kid where we have the famous Perry-Rubin syndrome. And these are the causes of his difficulty intubation, where he has a macrognasia and glossotosis. These are the criteria of difficult intubation. There was an interesting case where there was a difficulty to remove the fiber optic tube from the trachea tube, and they find that it was obstructed because the fiber optic was passing through the Murphy's eye. This is the Bollard laryngoscope. All these are tools to facilitate the endotracheal intubation. And then we have different types of anticipating difficult airway apart from the Malibati. We have the Wilson risk, as we can see, and we have the lemon lobe with the 3 or the 5 beginning letters to show what was the meaning of lemon low. And this is a figure where we have the anterior mandibular diameter and the posterior and the total mandibular diameter, and the correlation between the total mandibular diameter to the posterior mandibular diameter can give me a hint about the anticipated difficult airway. And this is Arne's risk index. All this you can try to increase its size to visualize. Of course, they find difficult sometimes to introduce the endotracheal tube through the fiber optic through the between the cords. And in such circumstances, sometimes we use the bevel downwards instead of upwards, and we keep manipulate moving the the tongue, trying to remove extract the tongue, or to move the mandible. All these are the ways to try to facilitate the introduction of endotracheal tube through the course. And this is one of the known endotracheal tube called a Parker Flix, where we have a end which looks like the bull nose. This point is pointed to the middle. This makes the introduction through the course with the fiber optic bronchoscope easier. And this is the type of bronchoscope where it does not utilize the fiber optic method. It uses a light emitting diode instead of the known fiber optic bronchoscope. Of course, all these are methods to anesthetize the gross pharyngeal nerve by putting swabs and pledges in the piriform fossa for a long time to block all these nerves. Gross pharyngeal nerve, of course, we can, of course, locally block it by introducing the needle, and we make a bend at the end of the needle so that we can go to the lower part of the anterior pillars of the tonsils on each side to inject to block the gross pharyngeal nerve. But you ought to use the cricothyroid membrane injection to block the recurrent laryngeal nerve. Sometimes we use a peristyloid approach for the glossopharyngeal nerve block. So this is a way where we make a point between the styloid process and the mastoid. In between, we divide the distance, and then we go to by a needle, and this needle hits downwards. So this is the way to block the glossopharyngeal nerve, apart from injecting through the pillars. It was found that the optimum plasma concentration, you ought to remember, it's below 5 microgram per milliliter. So this is the optimum. So the local anesthetic being used is around from 8 to 9 milligram per kilogram. This is the way to figure out the amount used whenever I'm going to do what we call topicalization. Apart from whenever I do nerve block, I ought to be confined to from 2 to 3 milligram per kilogram. The bad things about the nebulizer and the atomizing modalities, it works for a short time. This is why whenever I use this method, I must be assured that I'm going to do this or end the process of fiber optic intubation within 10 minutes. Of course, sometimes we can gargle the local anesthetic we put local anesthetic in some water and make the patient gargle this amount for a time. This will block most of the mouth. And then whenever it goes with the fiber optic bronchoscope, I use injection all the way. Also, the nasal ray tube and the ray tube, the first time to know that it is the abbreviation of what we call ring Adair Elwin tube. This is a tube. It has a good length to help you during introducing the tube through the nose, and it helps you to succeed during fiber optic intubation. And this is some of the statistics used in the figure. The famous one is the T student test. Student test, it was taken after Gozet. He wanted to share his ideas with other statisticians, so the company refused. So he came out with the test being called a student test. So this is why it's being called student test. And he was asked to compare two fields of barley and sha'ir, and then he yielded two curves. As we can see, this is our curves, of course, Bell's curve, and these are made of histograms to perform of this curve. Of course, each curve has a mean and have a spreading all on both sides. So whenever you have your data fulfilling this, you can use the test, the t-test. But if the data is not well organized to make a bell-shaped, as you can see, curve, we ought to use another method. These are the two data he got from the two fields, and then he made a sum, but you add all of them and divide by the number. It was 16 and 16, and then he calculated what we call the standard deviation. As you can see, it's called sigma. This sigma is being called in the whenever they're going to make a full population statistic. You see, but yeah, if you are going to take a sample, it calls X bar, and then he got his data. He put them in a special figure, as we can see, the T value, and he figured it out to be 2.3. What does he do after that? He goes further to do what we call the t-test. So we have a t value and goes to make a t-test. He goes to a special table. This table has, of course, columns and rows. He chooses the critical or the magic critical value, which is 0.025%, 5% from all. And then he chooses this line, and he intersects it with the row from what we call the degree of freedom. Degree of freedom is simply we are adding the two types, which is 16 and 16, and subtract by 2, and then we go to this row, and then we intersect with the magic critical value, and we get a value and compare it with the 2.3. If the 2.3 is less than the critical value, this is called, we can reject the null hypothesis. So there is a significant. But if it is more, we cannot reject the null hypothesis. So we have two data. We have null hypothesis when we have to reject it. So this is the way how to estimate the T statistic. This is a nice table which was present in the thesis, where Dr. Mohammed LATEEF discovered, of course, a mistake. Whenever you calculate the mean, you spread the mean on both sides by what we call the standard deviation. So the mean was 99, and the standard deviation was suppose 1.4. So when you add 1.4 to the mean, I'm sorry, which is 99, you will get a figure more than 100. So that means that nobody has a saturation of 100. That makes the fallacies, you see. So it was nice of him to discover this point. Now we have what we call paired or non-paired. One meaning of paired test. Paired test that I'm unpaired, that I'm just comparing both fields, the data of both fields. But unpaired, that we are taking more data from each feed. In other words, I'm going to use this field on the right side. I'm going to take a sample with a special fertilizer and comparing it with another fertilizer, but in the same field, you see. So this is called pair. This is the figure. How do we do the distribution curve, as you can see, and on the both sides the alpha, which is the 5%. When I add each of them, it's the 5% of the total, 95% of the curve. This is another method for statistics called chi-square. Chi is the 22 word of the alphabet of the Greek. It looks like an X, but one of the lines are being inclined. So it's simply it's the sum. This sum we have in the numerator, the observed minus the estimated and the denominator is the estimated. What's the meaning of that? Suppose you are going to flip a coin, and the coin you are going to flipping 100 coin. So in your mind, you're going to say, okay, 50 of them is going to be tail and 50 will be head. But if you get another figure, suppose, as you can see from here, 62 and 38, is this normal, or there's something wrong with the coin, or the way you are flipping, you see? So you take these figures and you put it in this equation, and then you're going to get a figure. See, he's doing all this. You got a figure. This figure, he goes to the table, as we said before. This table has columns and rows. The column, of course, as we said before, the magic critical value, which is 0.05, and then we had two data. So do data we divided by 1 to get what we call the degree of freedom, and then we intersect both of them, as we can see, to get a figure. This figure is being compared with what we had figured out of the estimation. And if it is less, it is statistic. If it is not, if it's more, it's insignificant, or we can accept the null hypothesis. So this difference between the coins and the heads, by using this table, assures us that it was it is non-statistic. In other words, there's nothing wrong with the coin or the way I'm flipping. Now we come to the last one, which is the Fisher exact. It's nice to know the story of it. He was invited Fisher in a party, and one of the females told him that if you make a couple of cups, including tea and milk, I can differentiate between whether you in the cup whether you began with the tea or began with the milk. You see, so this is made him think about his how to judge her claim. So suppose we have it's made of two tables, as you can see, and we have cells. These are called cells. You ought to have not more than 5 in each cell. So we have male and female, and we have data regarding the two types of medication use, and we have figures on both sides. So we want to know whether this data is significant or non-significant. That means the good thing about this test that we are not in need of degree of freedom, or we are not in need of tables, as we know. So we keep on changing the numbers, assuming different tables, and then we each table of them we get the p-value, and then as long as it's two-tailed on both sides, yeah, the data can be on the right side, on the left. We multiply by 2. We add all this p-value, and then we go to the magic 0.05, and if it is more, it will be non-significant, or if it is less, it's going to be significant. And this is a hint about how do they figure it out. Suppose I have 4 balls, and we have 2 green and 2 orange. Each of them has a number. So suppose how different types of balls I will find whenever I take only two of them. So if I take 2 of them, I will only take 2 of them at once, be in orange color, and if only 2 in a green color, and the other are a combination between both. So we have a 1/6 of them is 2 orange, and 1/6 of them is green, and the rest of them is around 4/6. So we have an equation. This equation, as you can see, it looks difficult. We put the data on it, and then we get the p-value. If this p-value is less or more than the critical value, we can say that this data is significant or non-significant. These are papers I had got from the internet to show you. If you are interested in having a look, I can give you time enough for you to follow the paper. I'm going to sorry. And this, I'm sorry. So these are some papers I had got from the internet, in addition to what I had said. If you want to have more information, I hope I did a good job. The point that I want to mention is I hope that all professors try to do what I am doing, so that then our young colleagues can get benefit of any discussion occurring, because I'm sorry that most of the young colleagues don't attend such a session. The second thing is I hope that the English language is improved among our colleagues. And if you fail to write a paper in a good way, you ought to go to someone who is good in English, because really I find difficulty to correct the English way of my colleagues write. Wassalamu alaikum wa rahmatullahi wa barakatuh.